Some interesting questions, and again, as my colleagues have said, thank you for the invitation. And I'd just like to congratulate Minister Banachayu and Marius for the progress they've made since the last time I was here in setting up a system. The questions you asked about managed entry agreements, and I'd just like to, I don't want to go over the same territory as Finn, Driss and Jaime have gone over, and I very much welcome the initiatives of UNETA in terms of putting out templates and systems that provide clarity for European assessment and setting national systems in that context. And it's not just for the payers, it's not just for the clinicians, it's not just for the patients, providing clear information about outcomes and performance, clinical effectiveness, cost effectiveness, but it's also, and I want to, I'm going to be fair here. I'm going to sort of, give a sort of reference to the manufacturers, because they need some clarity as well. They need to know how the systems work and how to sort of develop their evidence base going into those assessment processes. I think Driss said early at sort of phase 3, I think at the concept, the manufacturer needs to think about who's going to pay for this and how they get proper reimbursement for their technologies that they're putting a lot of blood, sweat, tears, money into, and how they're going to see that rewarded, how they're going to sort of find the data that helps patients, clinicians, and payers make decisions about reimbursement. So, a long preamble, but back to your point. In terms of managed entry agreements and the future of them, it really does rest a little bit with the sort of global term uncertainty. With the best will in the world, the evidence that comes out of the sort of phase 3 and the clinical trials over a short period doesn't tell you what the outcome's going to be in the longer term. And that's part of the equation when HTA looks at the evidence. They don't know what the value proposition is in detail. And that's where managed entry agreements come into play, because it helps give comfort to those making the decisions around that uncertainty, if the price can vary a bit. In the UK setting, the NHS, National Health Service, it's a bit of a misnomer. It's not a national service. It's a lot of independent hospitals running their own management systems, and they have different criteria for providing treatments and providing outputs. It's also not an outcomes-based system. It's an activity-based system largely. I mean, I may be a bit unfair on the NHS, but moving towards somewhere where you're actually measuring those outcomes, it would be a great step forward in terms of having the data to say, yes, this is effective. And manufacturers can help here by setting up registries. And that brings me into the concept of innovative contracting, where you may well have opportunities to reward cures, reward longer progression-free survival. All those things are important in terms of payment, in terms of patient satisfaction, and the sort of clinician-patient interaction that's a good outcome that can feed back into an HTA assessment and maybe change the price a little bit. So managed entry agreements are very useful in terms of addressing uncertainty, and whilst it would be nice to have some outcome-based systems that reward manufacturers for good patient outcomes, they come hand in hand with some administrative burden, bureaucracy, and ways of addressing that, again, through some form of innovative contracting, where the manufacturer maybe gives more in infrastructure support, is perhaps a way forward in all parts of Europe. So I'm not sure whether I've answered your question, but I'm happy to sort of take subsidiary ones if I haven't.
Okay, thank you very much.